Hello and welcome to this touchIME conversation activity. My name is Waśkiel-Burnat and I am a dermatologist working at the Medical University of Warsaw in Poland. I am joined by Dr. Maryanne Senna, who is a dermatologist and director of the Hair Loss Center of Excellence at Lehigh Hospital and Medical Center in the USA. Today we are going to discuss alopecia areata, our understanding of the impact of the condition on the patients, the pathophysiology underlying it, and emerging therapies to treat it. The first part of our conversation is about clinical features of alopecia areata, risk factors, and disease burden. Alopecia areata is an autoimmune form of non-scarring hair loss. However, the scalp hair is most commonly affected. Alopecia areata can also involve other hair-bearing areas, such as eyebrows or eyelashes. Based on the extent of hair loss, alopecia areata can be classified as patchy alopecia areata with partial scalp hair loss, alopecia totalis with complete scalp hair loss, and alopecia universalis with complete scalp and body hair loss. Episodes of hair loss in alopecia areata usually last for several months. However, in some cases, prolonged course of the disease can be observed. In some patients with alopecia areata, we may observe nail abnormalities, with pitting and trachyonychia being the most common one. It has been shown that alopecia areata has significant physical and psychosocial impacts. Hair loss can cause eye or nasal irritation and can be associated with an increased risk of sunburns or disturbances in thermoregulation. Alopecia areata can be associated also with other autoimmune disorders such as vitiligo or thyroiditis. Finally, treatment of alopecia areata, which is usually prolonged because of risk of relapses, can cause some side effects. Hair loss in alopecia areata causes stigmatization and influence on patient relationship. It has significant impact on lifestyle and social functioning. It would bring us to the first question today. Dr. Senna, can you please explain the epidemiology of alopecia areata and why it is considered a polygenic autoimmune disease?
So alopecia areata is the most common non-scarring form of hair loss, second only to androgenetic alopecia. And we know that the prevalence of it has been estimated to affect about 1 in 1,000 people, and a lifetime risk of developing alopecia areata is approximately 2%, and this is worldwide. Doesn't seem to have any predilection for sex, so affects men and women equally. And most commonly, people will develop this somewhere in their third or fourth decade of life, but it can happen at any age. And we know that when the first episode of alopecia areata occurs in childhood or at a younger age, it tends to lead to a lifetime risk of more extensive disease. A genome-wide association study identified 14 genetic loci that are associated with the development of alopecia areata. And many of these are related to immune function that could also correspond to inflammation seen in other autoimmune diseases, like you mentioned, thyroid disease, vitiligo, also diabetes and inflammatory bowel disease can be associated. And a lot of these genes are involved in specific things like regulation and proliferation of regulatory T cells, interleukins 2 and 21, and also the activation of the ligand for the natural killer cell receptor, NKG2D, which of course has been identified as the main effector cell in the pathogenesis of alopecia areata. And so we know that these genes play a role, and we see that when there's approximately 15% of patients who will have a family history of alopecia areata.
Thank you very much for this very comprehensive answer. And now I would like to ask, what do you think are the most important considerations for establishing disease phenotype and severity?
I'm glad that you asked this question because since 1902, we have used the same classification system for alopecia areata, largely, broadly defining alopecia areata types into four categories, more or less. One is patchy alopecia areata, right? These round oval spots, some of which can be just a few, others can cover larger areas of the scalp. Ophiasis, which is the ear-to-ear band-like distribution on the back of the scalp. Alopecia totalis, which you referred to earlier as being total or near total loss of scalp hair. And alopecia universalis, total or near total loss of all scalp and body hair. Now, what is difficult about this classification is you can imagine that for patchy alopecia, that can encompass people from 1% involvement of the scalp all the way up to 99% involvement of the scalp. And so there is a huge range in severity within that is really not captured when we refer to someone as just patchy AA. In addition, these classification systems do not take into account things like loss of facial hair, loss of eyebrow and eyelash hair, which is something that you mentioned earlier, can have real implications as these hairs on our body serve important functions for us. And so many of us set out in the U.S. as a group of experts to try to come together to say, what are the factors that we see really impacting severity? And in addition to the percentage of scalp hair loss, we felt that there were other things that really impact severity. So the way that we broke it down was that 20% or less scalp hair loss would be considered mild, 21 to 49% would be considered moderate, and greater than or equal to 50% would be considered severe, looking at scalp hair loss alone. But then if a patient had significant psychosocial impairment, which, as you mentioned, so many of these patients understandably do, if they had rapidly evolving hair shedding that they're going to lose a lot of hair in a short amount of time, if they had involvement of eyebrows and eyelashes, that these things would increase their severity by one level. So that, for example, if someone had 40% scalp hair loss, but had a significant psychosocial impairment or had loss of eyebrows and eyelashes, this would make them into the severe category. And we felt that this was more in keeping with what we see clinically and a better estimation of severity in this disease state.
Yeah, thank you very much. I think it is important to remember that even very mild hair loss can have significant psychological impact. So in this patient, we will maybe choose more severe treatment. So thank you very much, Dr. Senna. And the last question contains short description of the patient. The patient is 22-year-old woman experiencing an episode of alopecia areata that has lasted approximately 3 years, following multiple shorter episodes from when she was 6 years old. She currently has 35% of hair loss, and she has lost most of one eyebrow with thinning of eyelashes on both eyes. She also has mild atopic dermatitis, which she controls with topical corticosteroids. She works as a receptionist at city law firm and is embarrassed by her appearance to the point that it is affecting her work performance. Her older sister had a mild episode of alopecia areata at age 18. What can we tell this patient about her long-term prognosis?
So this case really highlights important things to consider when you're counseling patients and thinking about how the severity of their AA. So in this case, we have a patient who developed alopecia areata for the first time when she was 6. As I previously mentioned, that makes her have an increased lifetime risk of more extensive disease. We now know, too, that she has this current episode of alopecia areata that's lasted approximately 3 years. So while 35 to 50% of patients can spontaneously regrow within the first year, we know that if there's a persistent involvement of the disease past that first year, the likelihood of spontaneous resolution starts to go down. In addition, she has greater than 30%, 35% hair loss. That's significant hair loss if you lose 35% of your scalp hair. And in addition, she has loss on most of one eyebrow and thinning of eyelashes. To me, this puts her alone, just the 35% hair loss, in a moderate severity category. You add the eyebrows and eyelashes, that puts her into a severe category. Also putting her into a severe category would be the fact that this is affecting her appearance and her work performance. And so that's also very important. The fact that she has atopy or atopic dermatitis also makes her prognosis for severity over time being more severe. So this to me is a patient in summary who has factors that will affect her prognosis, age of development very young, atopic dermatitis, family history, all more severe, likelihood of extensive disease, and then presently having 35% hair loss, eyebrow involvement, and the fact that there's psychosocial impairment. This is a severe case that needs to be treated accordingly.
Thank you very much, Dr. Senna, for this nice explanation. Now I will conclude the first part of our conversation. Amount of hair loss in patients with alopecia areata doesn't necessarily correlate with reduced quality of life. There are numerous risk factors for alopecia areata, such as genetic predisposition and the presence of allergic or autoimmune disorders. To understand the impact of alopecia areata on the patient, it is important to see the condition as multidimensional in its impact and to assess physical, social, and emotional impact of the patient. The second part of our conversation is about the role of immune system and Janus kinase signaling pathways in the pathophysiology of alopecia areata. Immune privilege is a term that is applied to certain organs that are able to tolerate the introduction of antigens without being attacked by the immune system. Immune privileged organs include the eye, the central nervous system, the testes, and the hair follicles. In healthy individuals, the anagen hair follicles is a site of immune privilege with a limited number of antigen-presenting cells, are locally generated immunosuppressants such as alpha-melanocyte-stimulating hormone, transforming growth factor beta, somatostatin, and macrophage migratory inhibitory factor. It causes a very low expression of MHC class I and beta-2 macroglobulin. In alopecia areata, the insufficient activity of immunosuppressive molecules results in activation of immune cells and production of interferon. It upregulates the expression of MHC class I and promotes production of the pro-inflammatory cytokines. The JAK-STAT pathway is pro-inflammatory signaling pathway, which has important role in alopecia areata. The pathway is activated when cytokines bind to the receptor. Then, receptor-associated JAKs bind ATP and become active. JAK activation results in phosphorylation and activation of STAT transcription factor, which is translocated to the nucleus and upregulates transcription of genes that are involved in production of the pro-inflammatory cytokines. It causes the collapse of immune privilege in hair follicles that also induce a feed-forward loop. Let's move to the first question. Dr. Senna, how does the inflammatory pathophysiology of alopecia areata affect our approach to diagnosis and management?
So, as you alluded to before, the loss of the immune privilege is one of the first steps in alopecia areata development, but we really don't fully understand why that occurs. Some people think it could be related to stress, but in general, we don't have a clear understanding of why that immune privilege breaks down. We largely diagnose alopecia areata clinically. It's rare that we're doing a biopsy, even in unclear cases or of alopecia areata incognita, where there could be more diffuse involvement and not patchy hair loss, which is a rarer subtype. Even then, the biopsy doesn't have very specific features that can really pinpoint the diagnosis. So there has to be a very high clinical suspicion, and in general, it's pretty straightforward diagnosis with those non-scarring patches of hair loss or larger areas of non-scarring hair loss. It's important when you suspect or make the diagnosis of alopecia areata that you do ask questions related to the patient's other symptoms, family history, personal history, to assess for other comorbidities, like we mentioned earlier, thyroid disease, atopy or atopic dermatitis, vitiligo, inflammatory bowel disease, and if there are symptoms or signs to suggest those things, to follow those up. In chronic alopecia areata versus acute alopecia areata, we know that patients who have a longer current episode of disease are less likely to respond to treatments. And that's any treatments, including the newer Janus kinase inhibitors. So patients who have had a current episode of disease without spontaneous regrowth, 7 years, 10 years, 20 years, it's not that their chance of response is zero, but it's much lower than someone who has had alopecia areata, say, for a year or 2 years. And we're very fortunate in the United States now. We've just received FDA approval, thankfully, for these Janus kinase inhibitors that have been really critical in treating our more severe cases, in addition to intralesional steroids, topical medications, and some of the other treatment options that we previously had for treating alopecia areata.
Thank you very much. What are potential triggers for the inflammatory response that leads to alopecia areata?
So as I was alluding to before, we don't have a really good, clear understanding of exactly what leads to the immune privilege collapse. However, there have been some studies to suggest that substance P, which is something released by our nerves during stress, the increase in substance P can actually lead to the collapse of the immune privilege. And so this is why, in some cases, extreme stress has been considered as a potential trigger for the collapse of the immune privilege. And similarly, environmental factors, viral infections, most commonly or recently the COVID-19, can also in that way alter the immune homeostasis and allow that collapse of the immune privilege. And certainly for patients who have genes that might predispose them to AA, one of these other things can certainly tip the scales, allowing for the development of alopecia areata.
I think it's very interesting that in some patients with alopecia areata, we really see a connection between stress and hair loss, but in some patients, we don't see this connection at all. So thank you very much, Dr. Senna, once again for the answer. How has understanding of the pathophysiology of alopecia areata influenced the development of treatment for the condition?
So as you were mentioning before, immune privilege is established by these complex immune mechanisms that basically lead to immune tolerance and suppression of inflammation. And these same cytokines are involved in the pathophysiology of alopecia areata. So when these cytokines bind to their respective receptors on the cell surface, as you so beautifully put in the earlier slides, that leads to the activation of JAKs that then phosphorylate and activate STATs. Those STATs go into the cell nucleus and increase gene transcription of pro-inflammatory cytokines, most commonly in AA, IL-15, interferon gamma. And that loop continues so that those cytokines are being created and then further perpetuating the inflammatory process. What JAK inhibitors have been able to do is block that pathway at the level of the JAKs, preventing the phosphorylation of JAKs and the transcription of those genes and pro-inflammatory process. And so they've been really incredibly helpful in stopping that process that leads to the development of alopecia areata, allowing the hair to grow.
Thank you very much, Dr. Senna, for this nice explanation of the JAK-STAT pathway and mechanism of action of JAK inhibitors. Now I will make short conclusion of the second part of the talk. It is hypothesized that there is a collapse of normal bulb immune privilege in alopecia areata for reasons that are not fully understood. Triggers for alopecia areata in genetically susceptible individuals include hair follicle trauma, viral infection, emotional or physical stress. The JAK-STAT pathway play a central role in the inflammatory response. Hair follicle destruction is mainly around the bulb area. If the inflammatory response can be controlled, hair is able to regrow. The third part of our conversation is about current treatment landscape and emerging therapies for alopecia areata, focusing on JAK inhibitors. The efficacy of JAK inhibitors in alopecia areata was first described by Craig Lowe and co-workers in 2014. The authors describe a case on 25-year-old man with plaque psoriasis and alopecia universalis. In this patient, psoriasis was treated with tofacitinib at maximum dose 50 mg daily. The authors observed reduction of psoriasis, but also, what is interesting, full hair regrowth. To date, we have more data about efficacy and safety of JAK inhibitors in alopecia areata. In BRAVE AA1 and BRAVE AA2 clinical trials, patients with severe alopecia areata were treated with baricitinib 2 or 4 mg per day or received placebo. At week 36, significant reduction in SALT score in patients treated with baricitinib compared to patients who received placebo was observed. In this study, serious adverse events were reported in less than 4% of patients, and the most common one included acne, elevated CK, and increased LDL and HDL cholesterol. In Allegro trial, patients with alopecia areata were treated with ritlecitinib 30 or 50 mg daily, with or without 1 month of initial therapy with 200 mg of ritlecitinib. Also in this study, at week 24, significant reduction of SALT score in patients treated with ritlecitinib compared to patients who received placebo was observed. Recently, THRIVE AA1 and THRIVE AA2 trials were completed. Available information suggests that deuterium-modified ruxolitinib is effective in treatment of alopecia areata. Now let's move to the first question. I have a patient aged 25 years with active alopecia areata and a current SALT score of 30%. She has pitting on her nails and loss of eyelashes. She is a real estate sales representative and perceives customers' discomforts around her, which she believes is making it difficult for her to meet her sales targets. Based on current guidelines, what would be the most suitable treatment to limit her hair loss? Dr. Senna, please can you answer?
Yeah, so first I'd like to take a moment just to explain to the audience what we mean by SALT score, because this is not something that's typically used in clinic. The SALT score stands for Severity of Alopecia Tool, and this is a tool that was developed for use in clinical trials. You can basically think about it as an approximation of percent scalp hair loss. So this patient is 25 years old and currently has approximately 30% of scalp hair lost. She also has pitting on her nails, which is a poor prognostic feature, as we mentioned previously, and loss of eyelashes. So she's at 30%, which would put her sort of in that moderate category, in that clinical scale that I alluded to earlier. She has loss of eyelashes. That alone would bump her up to severe. But she's also having some psychosocial issues in that she's unable to do her job because she's having this perceived discomfort on the part of her customers when she's trying to work as a real estate sales representative. And so again, that would also put her on its own into a severe category. In my severe patients with alopecia areata, this is when I really start to think about the use of Janus kinase inhibitors, because we know that these severe patients are unlikely to have spontaneous remission or respond effectively to other treatments that are sometimes used for alopecia areata. And so this is a case where I think the indication for a Janus kinase inhibitor is present, and that would be my discussion with this patient.
I think it's worth to emphasize that in not all countries JAK inhibitors are so widely available. But I hope they will be available soon and we can treat a lot of patients with JAK inhibitors.
That's a very good point. In fact, in the United States, only recently did we have FDA approval of these medications, and it's really, made access to these treatments so much better for patients. And so I do feel for you there, and hopefully you'll have that soon.
Yeah, me too. Okay, let's move to the second question. What is the current understanding about rate of response of JAK inhibitors and also the durability of response with them?
So, like I say to my patients, if you have high cholesterol, you don't expect to take a cholesterol lowering medication for 3 months and then have perfect cholesterol for the rest of your life. Our bodies go back to whatever they were doing and reset if you're not taking the medication. And the same is true with the Janus kinase inhibitors. So patients do need to be on these medications long term. And in the clinical trials, it was shown the endpoint was at 36 weeks of treatment. And they looked at patients, and these were very severe patients in the case of the baricitinib or Brave AA trials that you mentioned. On average, these patients had 85% or on average 85% scalp hair loss. And that 39% reaching that endpoint, that means 39% of those patients had at least 80% of their scalp hair in place by the time point of 36 weeks. But these patients do need to be on them long term. Now, non-responders, identifying them is sort of difficult, right? So I mentioned earlier that if patients have very long-standing current episode, 7 years, 10 years, 20 years, it's not that their chance of responding is zero, it is just lower. And you need to set that expectation with patients. I think that's very important. Also, in the Brave AA trials, they did a pooled subgroup analysis and looked at patients who had a baseline SALT score, so again, approximating the percent scalp hair loss of 50 to 94%, compared to a group that had 95% scalp hair loss or higher. And what they saw was that the response rates were much higher in the severe versus the very severe group. So in the severe group, 48% of patients reached that endpoint of having at least 80% of their scalp hair back, whereas only about 21% had it in the most severe or very severe group. Now, that helps us in counseling our patients as well, because we can say, okay, you're in this category. This is what we see. We see a higher response rate. But also, in the very severe patients, we can say to them with confidence, there is still a chance for you to respond to these medications. I think that's very, very important. Adherence, of course, is important with any medication, compliance with the medication. Possibility of treatment holidays, that's a little bit trickier because we run into a situation where it seems as though if patients are consistently off of a medication, of these Janus kinase medications for 2 to 3 months, that's when we start to see some patients losing efficacy and starting to shed. However, in the baricitinib trials, they also did an important study, part of the study where they looked at dose titration. So for patients who were on that higher dose that you mentioned of 4 milligrams a day, and that reached that primary endpoint of regrowing 80% of their scalp hair or more at 36 weeks, half of those patients were reduced to 2 milligrams a day. And when they reduced them to 2 milligrams a day, the majority of patients were able to maintain their response. So while treatment holidays or discontinuation of treatment is probably not possible, we know that we can maintain patients on a lower dose of the medication to maintain that efficacy.
Dr. Senna, thank you very much. When we are discussing JAK inhibitors, we need to also think about side effects. What are some of the main safety concerns with JAK inhibitors, and do you recommend specific protocols for supporting patients in managing potential side effects?
So the first thing here is to understand that the black box warnings that are present for baricitinib, including serious infections, major adverse cardiovascular events, pulmonary embolism, and blood clots in the legs or deep vein thrombosis, these were based on tofacitinib in the rheumatoid arthritis population over the age of 50, who many of whom also had cardiovascular disease. So when I counsel my patients on this, first, I make sure they're not a patient who is, on other immunosuppressants. You would never combine a JAK inhibitor with another immunosuppressant. That puts them at increased risk of infection. Or a patient who has a history of recurrent or chronic infections. We always screen them at baseline for things like latent tuberculosis or hepatitis to make sure that those wouldn't be present at the time of initiation of a Janus kinase inhibitor. But the other black box warnings in the case of the baricitinib clinical trial did not seem to have a major signal in the alopecia areata patients that were included. Over about 1,200 patients were included in that trial. But when these things did occur in rheumatoid arthritis, they occurred in patients who had cardiovascular disease, who were over the age of 50 and had a history or current smoking of cigarettes. And so you do need to talk to your patients about this. I also ask about any personal or family history of blood clots. And so you want to have these conversations and when you're weighing the pros and cons of starting a medication like this. As far as guidelines for managing risks, in addition to asking those things in the history and review of the patient's medical, other comorbidities, medications, the general safety considerations are laboratory monitoring. And what I do is a complete blood count, complete metabolic profile, and lipid panel, and do that at baseline in addition to the TB and hepatitis screens that I mentioned. Then again at 3 months, and then every 6 months thereafter.
Thank you very much. And now I will ask the last question today. With the recent approval of baricitinib and other JAK inhibitors on the horizon, what key changes are needed in terms of clinical guidance to optimize patient outcome?
So we need to really make sure that when we're assessing our patients, we're not just going by their percent scalp hair loss. I think that's a big take-home message for the audience to understand that, it's not just their percent scalp hair loss. There are these other features like, are they responding to the treatment that you have them on? Do they have facial hair involvement? Are they being impacted in a psychosocial way? Is this impacting their day-to-day life? And is this something that's really dramatically progressing in front of your eyes? These are things that would make the alopecia areata more severe and be an indication for treatment with the Janus kinase inhibitor.
Thank you. Now I will make conclusion of the third part of our conversation. Data from clinical trials and off-label experience show JAK inhibitors can control the inflammation response in alopecia areata with significant proportion of patients experiencing hair growth. Patients must take JAK inhibitors for life. Hair growth does not reliably resume following breaks from treatment. The safety profiles are generally positive, and dosing can be titrated if necessary to manage side effects. With greater recognition of the broader impacts of alopecia areata on patients, together with treatment that can effectively disrupt the inflammatory feedback loop, guidelines for the management of the condition will need to be updated. Thank you, Dr. Senna, for very interesting insight into alopecia areata, its pathophysiology, and some of the new and emerging therapies to manage it.
Thank you. It's been a real pleasure talking with you about alopecia areata and our increasing understanding of the condition and how to manage it.
I would like to thank the audience for participating in this educational activity. I hope you enjoyed the session and found the insight offered here useful for further developing your clinical practice. Thank you.